A reproductive endocrinology and infertility specialist, both Canadian and American board certified, and you are watching Fertility Fact or Fiction. Welcome to our show. I am here with my good friend Tarek Ibrahim from Ibrahim Strategies Group, and we are going to present a very cool article tonight for patients that are going through IUI and have PCOS. And then we're going to take your questions live, which we do pretty much every week to try and help people learn more about fertility, know what works, what doesn't, and make their journeys a lot more successful. Want to make sure that you get a chance as you're watching to hit the subscribe button or follow button on whatever social media platform you are on. If you're watching us on YouTube, want to say a huge thanks to the ever-growing community of YouTube followers for us. We've had over 120,000 views just in the last month alone, and we get about 10 to 20 followers per day, which is nice. So super thrilling for us, very exciting, and just want to say thank you to everybody on all the different platforms. Instagram's been growing lately too, and so it's been really great to see the fruits of our labors. So thank you for that. We appreciate it, and Tarek appreciates it because that's his job. So very cool for us to see that. So hope you guys have all had a good week. Nothing really huge happened in the fertility world recently. Everything's been kind of status quo until I saw this article. So it was a choice between this one and another article, which I'll probably review next week, which compared doing day 3 embryos to day 5 embryos. So some people still believe in day 3 embryos. In fact, my embryologist from the last place I worked swore up and down that day 3 embryos were just as good as day 5. The majority of the world does not believe that that's the case, and I would definitely take issue with him on that topic and many others. And so it looks like overall that the day 3 versus day 5 thing has some interesting new data available from a new study that kind of compared the two. So I think that's something worth looking at. But this is kind of an interesting opportunity to look at something that's very common in the fertility world, which is, do we do just pills like Clomid or Letrozole for PCOS patients? Or do we do shots for the PCOS patients? Or do we do a combination of pills and shots? And so this study actually looked at a comparison of the pills versus the combination. And they used a very unique protocol, which I've not seen before. And the question was, does adding in some shots help you and get you a better outcome? And so we're going to find out together tonight. Because if it does, and their protocol works, it would be really interesting because they're only using it for 3 days, which is a very short duration to use shots for. Keeps the costs really low, so it makes it manageable for most people. And if it improves your success enough, it would be worthwhile, the extra investment, the extra monitoring, and so on. So let's find out together. Okay, so the study is called Sequential Letrozole Gonadotropin versus Letrozole alone for ovulation induction in infertile women with PCOS, a randomized controlled trial. So it kind of spells out the whole story for you right there. They took a group of women, 174 to be exact. They randomly assigned them, as long as they found out that they had PCOS, to either getting just letrozole, 2.5 milligrams per day for days 3 to 7 of the cycle, or 2.5 milligrams per day of the letrozole from days 3 to 7, and then day 8, 9, and 10 of the cycle with no pre-monitoring at all. They gave them 75 units of Menopur or HMG in that study. That's human menopausal gonadotropin. So for us, we would probably use Menopur for this. So super cool, very simple design, randomly allocated. Everybody had the same criteria. They all had PCOS. And then they took them and they said, okay, you're getting straight letrozole, which is the current first-line therapy for women with PCOS, or you're getting letrozole, and we're going to give you just a couple of shots to see if we can kind of perk things up and get a better response. Primary outcome was the number of women that actually ovulated, and then they looked at clinical pregnancy. They actually had data on live birth. They had data on miscarriages, ectopic pregnancies, twins, like pretty much everything you could ask for. I'm going to apologize. This is a preprint. It's a proof. So I wanted this data out to you because it's very interesting data for everybody to be aware of. And the way that it's presented is suboptimal for visualization. But I will share it with you so that you can see it and make sure that you can catch some of the stuff. And I'll try and circle it and show it to you when we get there. Okay. So how many women were there? As I mentioned, 174. And they randomized them into the 2 equal groups. And the process involved the study being from August of 2019 until January of 2020. So they collected these patients fairly quickly over a short period of time. Obviously, sometime around January of 2020, COVID was breaking out. And this study was done in China, so I'm assuming that they shut it down because of that reason. But they were still able to maintain the data on what happened to the patients afterwards. The PCOS patients were defined by the Rotterdam criteria. So they either had irregular periods, hyperandrogenism, which are signs of having high testosterone or male hormone levels, polycystic ovaries on the ultrasound. They had to be 18 to 40, so they weren't including women that were much older. And the duration of infertility had to be more than a year. They had to have open tubes, and the spouse had to have reasonable sperm quality, nothing major there. So any allergies, inability to cooperate, severe endo, severe kidney, heart, organ system dysfunction. They kept all of those people out, and no one that had any significant problems with their uterus, like a septum or large fibroids or anything like that. Okay, so we are going to just go quickly through what they did again. So they took these 2 groups, they randomized them. One group got 2.5 milligrams of letrozole, which is like the very low starting dose. We usually use 5, but that's fine. They used 2.5, and they got that from day 3 to 7 of their cycle. And the other group got 2.5 from days 3 to 7. And then from day 8 to 10, with no monitoring yet, they did extra dose 75 units a day of a human menopausal gonadotropin. For those of you watching, that would be something like Menopur. And then they analyzed everybody with ultrasound on day 11 and then decided when to trigger them based on follicle size. When they had enough of an appropriate follicle size, they triggered the release of the follicles, same criteria in both groups. And then they went ahead and told them to have timed intercourse. So this was not even an insemination study. It was just timed intercourse with the trigger shot and the medications that were given. Okay, so what did they find? Let me go to figure 1, which is way through here at the end. Okay, so if you can screen share. So you can see at the bottom of the screen there, and again, I apologize, this is pre-proof. They didn't have it in a really structured format. Age was pretty young. Most of these women were in their mid-20s, mid to late 20s. Obviously, almost everybody's Asian. The interesting thing in this PCOS group is the BMI. So as you can see, the BMIs are actually in the lower range. So the majority of these women are thin PCOS. Very few would have been heavier women with PCOS. So a little bit of a difference, and you've got to account for that when you're looking at the data. Do we know for sure that this would be applicable to women that have PCOS with weight concerns? We don't. That would have to be a different study. But at least in the thin PCOS, this applies. And I would anticipate we would probably get a similar result in women that are heavier. So fertility history, most of the patients had primary infertility, had suffered with it for some time. Their hormones were all more or less the same. There were no significant differences there. They did monitor very carefully all of their sugar, glucose, insulin metabolism, and all of that was pretty much the same between both groups. No huge differences there. So if you look at table 2, and I'll try and draw some stuff on for you here. So yeah, I don't know how much I can expand that. How's that? Is that good? Okay, so in the first column here, you've got the letrozole group, and in this column, you've got the letrozole with the human menopausal gonadotropin. So you can see down here that and I better pick a thinner pen so everyone will be able to see this, or maybe yellow. So you can see here that 61 out of 87, or 70.1% in the letrozole group ovulated. In the letrozole plus the HMG group, it was 79 out of 87, which was actually almost 91%. So almost a 21% increase in the number of women that will ovulate by just adding 3 extra days of a shot, which is huge. That's really good. We want to see that. The relative risk difference, 1.3. And when they looked at this in terms of absolute difference, as I mentioned, it was 20.7%. So very substantial and very highly significant. So the p-value is kind of scrunched, but it's 0.001. So very, very strong data. More importantly, what they showed was, and I'll switch to yellow here. So what you can see here is that 9 out of the 87 had a live birth in letrozole. So roughly about 10%, which is reasonable, but it was 20 out of the 87 in the letrozole plus HMG group. So why is this really critical? Well, traditionally, when we talk to patients about getting just letrozole for PCOS, we tell them you got about an 8 to 10% chance of getting pregnant every month. A little bit higher if you add in insemination, you're looking at maybe 15%. When we use shots alone, we know that we can get you up to that 20, maybe sometimes even 25% rate with insemination, and on its own, somewhere around 15 to 20. So what this study is showing us is you can actually get a very high success rate, about 23% in this study, when you use the letrozole with the HMG together. And that's very, very valuable information, because usually letrozole with the shots gets you an in-between number between that 10% and that 20%. But this is actually saying you can get a very high success rate with just 3 days of these shots added in. So relative risk, again, 2.22, so 122% increase in success. And that works out to an absolute difference of 12.7. Again, super, super statistically significant. Okay, so I'll flip the page. Whoops. Okay, so if you look here now, and I'll have to scroll through this, when they did their per protocol analysis rather than intention to treat, the numbers were still essentially the same, higher rate of ovulation in the double group and a higher rate of live birth. So intention to treat is you were assigned to this group, you stuck in that group or didn't, we still analyze you like you did. Per protocol means what did they actually end up doing? Either way in this, highly significant results showing that the letrozole plus 3 days of shots doubled your success rates and significantly increased live birth. When they looked at the number of patients that had single ovulation, in the letrozole group, it was 51.7%. In the letrozole plus AMG group, it was actually even higher, which is unusual because normally you would think the shots would push it a little more, make you make 2 eggs, but in this group, it actually helped them make just 1 even more frequently. Conception, which was just your positive beta HCG, 17.2% in letrozole, 33.3% in the letrozole plus HMG. So huge increase, and that's a very substantial number. So you're now looking at a very high success rate to just get pregnant using this protocol. Clinical pregnancy, where you can see a heartbeat, 13.8% with letrozole alone. Again, doubled when you go to the letrozole and HMG at 27.6%. Super important for us, what's the difference in terms of risk of twins? Because the reason people always shy away from doing the shots is, whoa, what happens if we end up with twins? We don't want to end up with twins. That's really risky. So what should we do? And the answer is, if you look here, the singleton pregnancy rate was 12.6%. In the letrozole group, it was 27.6%. in the group with both. So you're actually getting a higher rate of the chance that it's a singleton when you did this. Now, when you go to twin pregnancy, it was 1.1% in the letrozole group. And ironically, it was 0% in the letrozole plus HMG. I find that surprising, and maybe it's just a fluke in the study. But again, it's a significant difference, and that's important for you to know. Ongoing pregnancy, 11.5, 25.3%. Pregnancy loss, 5.7 in the letrozole group, 8% in the letrozole and HMG group. But if you scroll over to here where you can see me circling in the yellow there, it is not statistically significantly different. They also saw, no difference in any of the factors related to miscarriage, fetal death, or any of those elements. So ectopics, abnormal pregnancies, any of that stuff. It was all essentially the same. So the next part of this was just some extra analyses. And at the end of it all, when they analyzed it, they said the chances of success when they stratified for reproductive outcomes was sky high. So you can see, and again, this is pre-proof, so it's hard to estimate. But if you looked at women with a reasonable BMI, and they looked at the chance of ovulation and live birth subsequently, if I highlight it for you here, you'll understand. You have a 275% increase in the chance that you would successfully have a live birth if you have a reasonably low BMI or just slightly overweight, and you are attempting to use the letrozole with the AMG. If your BMI was over 28, they use that as the reference group. And then if you were very high BMI, which was the strata 4, you still had a higher success rate. And same thing with strata 5, it was still a higher success rate. So all of these show a significant benefit, except in that last category, it was not statistically significant because the p-value was over 0.05. So where does all this leave us? Well, the reality is that all of us, every fertility specialist I know, typically will turn to letrozole to stimulate patients with PCOS, if they have oligoovulation, they're not ovulating. And some of us will use shots, but I tell patients all the time when they have PCOS, if I use shots and you have very strong ovaries, there's a very good chance I'm going to turn you into Octomom because we control over how many eggs you have. In fact, we have to bring some of them and drain their eggs here before we do the insemination in order to proceed, because some people would just make too many eggs. This study, using this very unique protocol, shows that with just 3 days of shots, so you're talking about an extra couple $100, you can actually double the success rates and get very good increases in live birth rate that are very meaningful and powerful. So we will start implementing this very soon from now on. For anybody that can afford the extra bit of shots, we're going to start doing those shots and implement that into the letrozole program that we do, especially when we're doing IUI, because this is a very good way to get singleton pregnancies in PCOS women with a very low additional cost and no significant increase in intervention other than 3 shots. So I love this study. I think it's a groundbreaking study. I think it's a paradigm shift. I'm hoping there will be other studies, hopefully in the American population. I may even try and duplicate this here in our own PCOS population to see how it applies in women who are a little bit heavier and have a higher BMI. So super cool study, very interesting data. Is it a fact or a fiction that using letrozole with injectables together just for 3 days, if you have PCOS, will improve your live birth rate? It actually is true. It will improve your live birth rate and your success rate. No difference in miscarriage or abortion or ectopic. Way better outcomes, very, very strong results, and super cool information to share with you all. So I hope you enjoyed that part of the show. We are going to ask you guys to comment. Always like your comments. What do you think of this study? Do you think we should try one here? Let us know. And make sure you hit that like button and subscribe. So we're going to take your questions live now.